Good morning, everybody, to our first invited talk of our FRPT conference. I'm Andreas Schuller from PDB, the National Metrology Institute of Germany, and I chair this session together with Manjit Dosani from CERN. And yeah, it's a great honor for me to announce here Billy Liu. He is from Stanford, and we are especially very grateful to him because it's midnight in California right now. Billy Liu is a professor of radiation oncology. He is a physician scientist, and he not only received a PhD, but is also an MD. He is co-author of a number of recent publications about FLASH studies. He and his colleagues from Stanford converted a clinical LINAC to achieve ultra-high dose rate almost immediately after the first publication of the FLASH effect. And he co-lead the collaborative effort between the Stanford Cancer Institute and SLAC to develop a new generation of LINAC technology called Phaser. We heard yesterday already from Sami Tantavi, which may be the key for the clinical translation of FLASH radiotherapy. So I'm looking forward to your presentation. The floor is yours.
All right, thank you very much. Let me share my screen. Are you able to see it now?
I see it very well. I hear you well, Will. Please start.
Excellent. Okay, thank you so much. It's a real pleasure to be able to join this conference virtually, and I'm very thankful to the organizers, and thank you for that very kind introduction. So I was asked to speak regarding FLASH, the path to clinical translation. And in fact, as you have already heard through this conference, although the title has a question mark in it, indeed, there's really no longer a question because clinical translation has already begun. I'll touch on that, but also touch on many questions that remain in order to have a full clinical translation. These are my disclosures. And you've already heard some of these basic concepts, but I think we separate now the notion of the physical and technological aspect, which we call ultra-high dose rate radiation therapy, which refers to radiation deliveries with dose rates that are at least 2 to 3 orders of magnitude faster than the conventional clinical electron or X-ray treatments that we use. However, the biological aspect is what we refer to as FLASH radiotherapy, which is ultra-high dose rate radiotherapy that actually produces a higher therapeutic index in vivo. And so there's the two aspects of tumor killing that's at least as good as the conventional dose rate, but reduced collateral damage to normal tissues. And so this is a biological effect that we hope will also be a clinical effect as we translate it to patients. And of course, as you have heard already, clinical translation of FLASH has already begun. This report of the first in human case, which was treated by Professor Jean Boris at the CHUV in 2019, was a landmark event. But now, indeed, as you've already heard at this conference, the Cincinnati FAST-01 is the first prospective proton feasibility trial of FLASH, and has already completed accrual of its planned 10-patient cohort. So that's also an important milestone. Again, at the CHUV, the first prospective phase 1 impulse trial of electron FLASH has started accruing patients for cutaneous metastases from melanoma. So clinical translation has already begun. These trials are focused primarily on both feasibility as well as the designs based on what has been demonstrated in preclinical studies, or what has been explored in preclinical studies, which is really a very limited space. For example, the majority of the preclinical evidence is based on single large fraction treatments. And that's how these clinical trials have started, but there's much to be understood as we try to optimize translation to the clinic. So what are some of the clinically relevant questions which are currently incompletely answered? One important question is what we mean by speed. How fast is fast enough? What are the actual dose and dose rate parameters to achieve the optimal flash effect? Does the flash effect hold under fractionation, which is obviously the most common way that radiation is given in the clinic? And is there a dose threshold to achieve flash effects? What about combinations with systemic therapies? That's something that's currently largely unexplored in preclinical work. And is it important what type of beam, what the RBE is? These are, again, questions to be answered more completely, although I'll be discussing some of each of these aspects and doing a very selective survey of preclinical studies that have been done to date that touch on these areas, and also touch on some of the technological questions, including what can be treated with technologies that we currently have, but also what do we really need to achieve highly conformal flash radiotherapy of more general cancer targets, in other words, large volume and deep-seated targets. So looking first at the aspects of speed and flash dose rate parameters, you've seen some of these data before, but I'll kind of focus from this question. So Pierre Montegruel published this study back in 2017, looking at sparing of cognition by flash whole brain radiotherapy, and finding that at different dose rates, there was a differential effect. And so you can see here that roughly 30 gray per second was where there appeared to be a transition in the effect on cognitive sparing. So somewhere between 30 to 100 gray per second appeared to be necessary to achieve the full sparing of cognition by flash. Pierre also did this study in collaboration with collaborators at the ESRF facility using synchrotron X-rays to treat whole brain in mice. The previous study was with electrons. So finding very similar effects with synchrotron X-rays, sparing of cognition, sparing of neural progenitor cells in the hippocampus. But the difference in this case was that the radiation was delivered as a narrow blade that was swept across the brain. So within that very narrow 50 micron blade of X-rays, the dose rate was 12,000 gray per second. But as it swept across the brain, if you average the entire time, it comes up to 37 gray per second. So nominally, maybe not enough to achieve the full flash effect, but yet that was observed. So that suggests that the spatial and temporal distribution is important. That as if the dose rate that is seen by volume of tissue is high enough, as long as there's not crosstalk from the scanning process of other slices, that may be adequate to achieve the full effect. This is a study that we did at Stanford, again, with electrons, whole brain radiation in mice, showing very similar findings, sparing of cognition by flash, reduced change in the dendritic spines of the hippocampal neurons, less neuroinflammation. But the way that we did this study was flash was a high dose per pulse, high repetition rate. But the way that we did the conventional was keeping the same dose per pulse, but spreading the pulses with gaps in time over a longer total delivery time, and finding that produced the conventional type of effect, whereas the flash produced the sparing. So it suggests that the total delivery time may be an important parameter, even for the same dose per pulse. These parameters were explored by the Oxford group in an intestinal irradiation model. So this is looking at crypts in the intestines of mice after whole abdominal electron irradiation. They also looked at the effect of age, and so younger versus older mice. So there's a lot of data here, but if you look at the right-hand side, what they broke out was here studying the effect of constant delivery time of 1/10 of a second, but with different numbers of pulses and therefore a different dose per pulse. Here they looked at only 2 pulses, same dose per pulse in all cases, but with a variable gap between the 2 pulses. And then here's all the data combined. But in all these cases, finding that there appeared to be a sort of a threshold between flash sparing of the intestines versus not. So there appears to be a threshold-like effect. Whether it keeps getting better with delivery times as short as a single pulse, it was not consistent in all cases. But just at a very high level, there appeared to be an age-dependent dose response. Of course, we might expect that. We might also expect an organ system-dependent response, a species-dependent response. So those are all possible. But also, there appeared to be a threshold where the total delivery time needs to be, some fraction of a second, that there needed to be a minimum mean dose rate, and possibly a threshold of dose per pulse as well. So it's hard to say for sure with these data, and there was kind of a range in the results, but those are the general findings. What about fractionation and kind of bringing it to more widely used clinical regimens? So this is work again by Pierre, showing the well-known result now that with a single dose of 10 gray whole brain electron radiation, that there's cognitive sparing with flash. Also that the orthotopic tumors were equally well controlled with flash versus conventional dose rate. But there's the normal brain sparing by flash. At a larger dose, 14 gray single fraction, we see a better tumor response, again, equal between conventional and flash. But now the dose is too high. So there's toxicity with both flash and conventional, and that's expected. Eventually, there will be toxicity with flash. It's not magic. So at this dose, it was too high in a single fraction. Now with 4 fractions of 3.5 gray, so this is a lower BED, the tumor control was less good as 10 gray in a single fraction. And now there's also little toxicity. None of the groups actually had cognitive deficits. So even in conventional, this was too low a dose to produce toxicity. But when there was 2 times 7 gray, we again see a roughly equal BED to 10 gray times 1, better tumor killing, equal between flash and conventional. Now there's sparing by flash. And a larger total dose, 3 times 10 gray, there's the best tumor killing among this experiment. But again, the flash protection of normal tissues is maintained across 3 fractions. And the tumor killing was sufficient to improve the survival of the mice. So it seems like some level of fractionation, the flash effect can be maintained. Is there a dose threshold? The previous data showed from Pierre didn't find enough toxicity using the low dose per fraction. These are in vitro studies now by Charles Fouillade at the Institute Curie, showing that in vitro there was sparing by flash of normal tissue cell lines, but not tumor cell lines. So there is in fact apparently a flash effect in vitro here. And remarkably at doses as low as 2 gray per fraction or 2 gray single fraction. So the kind of raising the question of where, if any, is there a dose threshold? Is there a lower limit or not? In terms of combinations with systemic therapies, these are data from my group at Stanford, and this was led by my collaborator, Dr. Aaron Rankin, looking at an ovarian cancer model in mice, finding that with FLASH, we see both sparing of the normal intestinal function compared to the conventional dose rate, as well as equal reduction of peritoneal metastasis tumor burden with FLASH and conventional dose rate. When we looked at the combination of FLASH with an immune checkpoint inhibitor, an anti-PD-1 agent, we found that the anti-PD-1 agent by itself did very little in terms of tumor control, but when combined with radiation, both conventional and FLASH, there was a substantial improvement in tumor control compared to either radiation or immunotherapy alone. Yet the FLASH sparing of the intestines was maintained compared to conventional dose rate, and the anti-PD-1 did not add to the intestinal toxicity. So showing that there may be super additive benefits on tumor control in combination with immunotherapy while maintaining the FLASH sparing effect of the intestines. In terms of beam types and potential RBE effects, we see that this is the work from the University of Pennsylvania group on their experimental proton beam line. And in this case, they tested both the entrance dose-based treatment, so shoot-through technique versus a spread-out Bragg peak. So Dr. Kim presented this earlier in this conference. They used a ridge filter to produce a spread out Bragg peak in the mouse abdomen. And they found that on tumors, that all of the radiation modalities, conventional and FLASH and entrance versus spread out Bragg peak, all produced similar tumor control. And on intestinal sparing, again, looking at the sparing of the intestinal crypts, FLASH, whether by entrance dose or Bragg peak, produced similar sparing, both better than the conventional dose rate modalities. Despite the expected difference in RBE between the entrance versus Bragg peak, the results seem to be similar, and the FLASH sparing was maintained. What about other beam types? So most of the work that has been done has been with electrons and with protons. This is a demonstration of MV photons using a superconducting LINAC at a free electron laser facility in China, and looking at irradiation of the lung and of the abdomen, finding a sparing effect by FLASH on the normal tissues, and also tumor control that they were not able to achieve exactly the same results, but certainly suggests that tumor control is no worse with FLASH, and at least comparable. So, so far, FLASH effects have been observed with all these different beam types: conventional energy electrons, protons, synchrotron X-rays, MV X-rays. We heard at this conference about FLASH effects being observed with carbon ions. So far that it appears to be an effect that goes across all beam types to date. So in terms of existing technologies for delivering FLASH potentially in the clinic, we have commercial systems that deliver both superficial electron beams and proton beams. Clinical trials, as you've seen, have already started. And these are suitable for a certain specific indications based on the limits of the technology. So of course, the electrons are going to be limited to superficial targets. With existing proton beam systems, generally, we're going to be somewhat limited in the volume of treatment, but also that any given fraction to have a FLASH delivery would have to be from a single beam direction. So that limits the potential conformity of the treatment. And so I would argue that to achieve the kind of full clinical use of highly conformal therapy to large volume and deep-seated targets, we do need new technologies beyond what is currently available. And so
5 minutes to go.
Okay, the effort that we've been working on at Stanford with SLAC, you've already heard the accelerator developments by my colleague, Sami Tantawi. And we've integrated multiple innovations into this concept that we now call phaser for producing a very high dose rate photon conformal radiotherapy. And so you saw these developments by Sami already, but basically with much more efficient linacs, we can produce much higher beam current with conventional power sources and take advantage of scanning beam techniques to produce intensity modulation without mechanical moving parts. Similar accelerator principles can be used to produce not just higher beam current, but also much higher beam energy. That leads us to very compact sources of very high energy electrons in the 100+ MeV range that has favorable depth dose characteristics compared to photons, or intermediate between photons and protons. And Sami already touched on the cryogenically cooled, very compact and low power requirement 100 MeV scale electron linacs. And Emilio Nani from SLAC is also presenting at this conference on using a similar sort of accelerator technology for proton acceleration and deceleration, as well as RF beam deflection. So able to achieve full 3D scanning of protons without physical degraders or scanning magnets. And so these are some technologies that could lead to fully conformal, more general cancer targets in flash with various beam types from photons to very high energy electrons to protons. So I'll conclude there by saying that ultra rapid flash has shown the potential for increased therapeutic index, certainly in multiple preclinical models, and the clinical translation has already begun. And just wanted to introduce that radically new technologies are being developed for general cancer radiotherapy indications, particularly deep-seated and large volume targets, using technology that has the potential to be very compact and efficient. But of course, much more needs to be studied biologically, technologically, and clinically. I'd like to thank many collaborators, many who I couldn't even include here, who have contributed to my own work in this field. And I'm happy to take questions. Thank you very much.
Yes, thank you very much for this nice overview talk. Very interesting, very impressive talk. I forgot to say at the beginning, please ask your questions in the chat box between beside the window where you watch the stream. So in the moment, we have no questions up to now. So I think it's a problem of the delay when you have to write in the times. Really, maybe you can, in the meantime, tell us a little bit about the next step with the phaser. Do you think that already in the next year it is we can see some results?
Using the new accelerator technology? Yes, we're actually currently building a beamline using this very high current linear accelerator to produce X-rays. It'll be the full kind of the phaser concept that I showed would have 16 of these so that there can be multiple simultaneous beam directions. But we're building a beamline using one of them that will have the full specs of what would be needed as one of the 16, but we'll be using that for preclinical irradiation. So it'll be X-ray flash for small animals. And the advantage being that with X-rays, compared to electrons, we can collimate the beam and therefore do conformal radiation. So we'd actually rotate the mouse rapidly to do conformal arc flash radiotherapy.
Yeah, thank you very much. Meanwhile, the questions
are coming.
Are coming. Yeah, please, Manjit, do you select one?
Okay, so thank you again. One fantastic talk. So what do you foresee, or it keeps moving, what do you foresee is the next clinical application in tumor site for FLASH?
Yeah, it's a good question. I mean, I think the field right now is taking a kind of a very stepwise approach. You've seen the trials with protons, really starting with a feasibility type of approach. So it's not using a dose that is expected to be toxic. It's just to demonstrate that rapid delivery can be done reliably and safely, which is a logical first step. The SHUV group is actually doing a phase 1 dose escalation study of single fraction flash. So there we have the potential to see, what doses we could escalate to and, still, have minimal toxicity. So I think that will be one of the first studies to kind of push the limits of, to see actual potential benefits from flash. Of course, other trials are going in that direction as well. So I think we'll start to learn more. Will we start to see some fractionated regimens? I think, the field as a whole, there's not quite the confidence there yet. But as we see, at least in some preclinical data that suggests that the flash effect is preserved with fractionation. So I think as those data come in, there may be more confidence to do fractionated regimens as well, and that will open up the.
Billy, we have only 3 minutes to go, but already 11 questions, and the most most asked question at the moment is: how important do you think is the understanding of the flash mechanism for clinical translation? Is it necessary to understand, or can we proceed?
Yeah, it's a great question and one that's debated a lot, right? So I would say that it's, of course, very important to try to understand the mechanism to optimize the impact of flash. I don't think we necessarily need to know everything about the mechanisms to start introducing it. The fact of the matter is that we know far less than we think even about conventional radiotherapy mechanisms, right? I mean, how much of that biology do we really know? So I think some of it can be, as we can learn empirically and see what can be introduced safely. But of course, it's important to understand the mechanisms to really get the optimal benefit.
So Billy, the next question in importance of a number of people asking is, do you think, or do we risk flash being less efficient to sterilize tumors compared to conventional dose rates?
Well, that's certainly the concern, is that if we see normal tissue sparing, could it spare the tumors? And so far, across multiple tumor models, there's very, very few that suggest that flash is less effective on tumor killing, and almost all showing at least ISO effectiveness. So that's encouraging. But it does, mean that we should proceed cautiously, and that's where better understanding of mechanisms will help us be at least more confident. But that, I think, again, by careful selection of the indications to proceed on, it's still possible to introduce some clinical trials.
The next question in the ranking is: should we ask the question, which beam parameters create the strongest flash effect, instead of just asking what delivery is fast enough?
Yes. Well, that's kind of the point of why there's sort of a distinction between ultra-high dose rate radiation versus flash, right? I mean, what about ultra-high dose rate is actually producing the flash biological effect? And so these are questions that remain to be answered. However, flash effects, the flip side, I would argue, is flash effects have been observed across a somewhat broad range of fast irradiations. And so again, there's a lot of opportunity to optimize, and we should and we need to, but we may still be able to proceed with some initial clinical introduction.
We come to the end because the time is over, but there's one final question that I want to ask you. Where is it? So what do you think when do you expect flash therapy to be the mainstream therapeutic option?
Well, that's always a hard one to answer, right? I think it'll depend on what we see from these first few clinical trials. And that could really be the spark that, ignites a big change. But I think we'll learn a lot more in the next 1 or 2 years.
Thank you very much.
Thank you again. So, Andreas, do we have to close now?
I think we are still live.
So if we have room for one more question.
Maybe.
Which of the technologies would be most effective for a flash at the scale we are talking about, according to you?
Well, I mean, I think what I've been working with my colleagues to push towards is that full kind of conformal flash treatment. And we believe that photons will be kind of the first of like the new generation of technologies that will be feasible to accomplish that, because the existing technologies can't quite do it all. So that's what we believe at this point.
Sorry, I forgot to say not just the most effective, but most cost effective, which is a very important point, right?
Yes. Well, that's been the focus of our work, is to ensure that the technology is both compact, power efficient, and economical.
Okay, thank you very much.